I'm Dr. Allan Perel, and this is Conversations in Medicine. I'm Dr. Allan Perel, and this is Conversations in Medicine, a show bringing the cutting-edge topics of medical care to the Staten Island and tri-state community. Today's program is about back pain, the most single common cause of disability in the United States. Over 80 to 90% of people have back pain at some time during their life. There are multiple names for back pain: lumbago, sciatica, and it's such a common process and problem that I have a wonderful expert here to help us talk about it and look at it, and we've got some models here, and talk about what treatments are available. As I said, over 80% of people will have back pain at some time in their life. 1/2 of all Americans have back pain that leads to disability. There are different things. We have strains, we have sprains, which are more muscular problems. We have pinched nerves or root problems, and sometimes even issues internally, like with your stomach or kidneys or other parts of your body, can cause back pain. So my wonderful and outstanding guest is Dr. Ken Chapman, a good friend. He's an expert in the field of back pain. He's a pain management specialist, assistant clinical professor of pain management at NYU Langone, and director of the Pain Management Center at Staten Island Hospital. Welcome.
Thank you. Thank you for having me, Allan.
So Ken, first question, how do I know I have back pain?
Well, our body has a built-in system to let us know these things, and those are through our nerves. And if you develop an aggravation, irritation to an area, the nervous system sends signals to our brain and says, hey, something's not right here. And it's processed there, and another response is sent back to the area, as well as through the central nervous system, and our body tells us.
So is it good to have pain?
For the most part, pain is, we've developed to have pain for a reason, and that's to tell us that there's a noxious stimuli, and to help us to avoid or maybe move away from something hot, or not let something extremely heavy rest on our body, or really help us or protect us, essentially.
So there's different kinds of pains. There's pains, as you said, to prevent problems from occurring, to not have more injurious process occurring. And there's pain that sometimes, and as a neurologist I see a lot of this, that's sort of central, that once the body's conditioned to have pain, it just persists, and that's something sometimes we have to break the cycle.
Well, sure. So, pain, as I kind of said earlier, pain is telling us something's not right. And, the amazing thing about our bodies is that many times if there is an injury, the body fixes itself. As a matter of fact, most of the time it does, if it can. So in those conditions where our body can't fix itself, that pain can persist beyond the normal expected duration.
When should someone be concerned about back pain?
Well, pain as we age, pain could be sort of part of the process of aging. But if, it depends on a couple factors, and one is the degree of pain that you're having, and the amount of disability you're having from that pain. So something like a low-grade ache in your back after moving furniture would be expected, and you can expect to have it for a couple days, whereas going to pick something up and developing sharp stabbing, shooting pain down your leg that can incapacitate you is obviously something that's not normal, and that you may want to get checked out.
So when do you decide to go to the doctor or a healthcare professional?
Again, if the pain is something that lies outside the boundaries of normal of what you're doing, or have done and is not responding in a normal time frame in a progressive manner of improvement, it would depend on how bad it was and how well you were progressing as far as getting better.
And that's interesting because as a neurologist, I know you're in your field, of course, pain management. I see a lot of people with neck and back pain. And a lot of the referrals that I get come to me because they've got numbness, weakness, tingling, things that go into their arms and legs. So tell me a little bit about where is the back and what parts are there of the back?
So, our I guess back, you could say, is made up of our spine, and there's the cervical, thoracic, and lumbar.
So which is
sections.
which part of your?
So our neck is is what we would commonly refer to. Neck is our cervical spine, and that basically goes from the base of our skull to really between our shoulder blades is where it ends. And we have 7 bones up there, and from our the top of our chest to about the bottom of our rib cage is our thoracic spine, and you'll have there's 12 vertebrae in that section. In our lumbar spine, there's 5 vertebrae, and here's an example of one right here. It basically forms our trunk and our neck.
And the reason what I've always understood, the reason that people get low back pain specifically is because we stand on our feet. And being bipeds, we actually stand up. And when you stand up, your legs, your lower back is really taking care of all the issues of exertion and locomotion of everything from your waist up. So it's sort of interesting. It's sort of a product of how we've developed evolutionary-wise.
Yeah, absolutely.
So let's talk about a person has back pain, and it's out of the realm of ordinary. It's not a day or two after you move furniture. Who should they go see?
Well, again, it depends. Back pain is one of the top 5 reasons that people go to the emergency room. Depending on the degree of pain that you're having, you could start anywhere from a physical therapist to a chiropractor, to a neurologist, your internist. Sometimes we'll see people early in the process when their pain is severe. But it kind of depends on where you fall in that scale. And for the most part, people will either see like a therapist or their primary care physician.
So usually, the way I think about it is, as you just said, the primary care physician is so important because they're sort of the gatekeeper of taking a look at you and seeing whether you need to go to a pain management specialist, a neurologist, what kind of therapy.
Absolutely.
I think in New York, we need to get a prescription to see a physical therapist. So you have to go through some type of healthcare professional. Or is that true?
My understanding is that the rules changed. You could see a therapist prior to seeing a physician, but I'm not exactly sure about that.
Okay. So let's assume someone's gone through some of the, how would you go, what would be your next step? So someone's got back pain, they've gone to the therapist, and we're going to sort of move a little bit ahead, because again, you being a super specialist in treating people with back pain that doesn't respond to most conservative therapy, what are you looking for? Both, now we're going to do the exam, and we're going to talk about what ancillary tests you really need to know what's going on.
Sure. So when someone comes into our office, the first thing we want to do is get a history from them, find out how long they've been having their pain for, how severe is their pain, what makes it better, what makes it worse, if it's radiating. After getting a history, we would do a physical exam and try to see if there's any findings that would back up or lead us to believe it was one diagnosis or another. And then there are tests along the way that can help us, and sometimes they've had those done already, sometimes they haven't.
Tell us what kind of tests.
Yeah, the most basic test someone would have would be an X-ray. An X-ray shows a picture of the patient's bones, but that's all it kind of gives us. And when it comes to the spine, very often many times we don't see that much on the X-ray that helps us, but it kind of rules out more severe things that we want to just make sure that are not in the
Give us some
picture.
examples. Always, it's always for our audience. We have a wonderful audience. Everybody likes to hear more, like wants to know the structures or what they're talking about. So you do an X-ray to see if there's something broken.
Sure.
Anything else that an X-ray would help you
Well,
with?
you know, on an X-ray, you could also pick up things. Fractures is one thing. You can see changes within the bone. So arthritis can be seen in an X-ray of the spine. Disc degeneration, that area between the discs will be narrowed. With certain types of malignancies or cancers, you can see on an X-ray. And those are the main things. Sometimes you get to see things are out of line on the X-ray. And so that, again, that would be the first test. And then the next imaging modality that's commonly used would be an MRI. And an MRI gives more of the images of the soft tissue of the spine. So in the MRI, we could see the discs, the nerves, the cerebral spinal fluid, the muscles, ligaments, and it really allows us to see more as far as what could be the underlying cause of the patient's pain.
I see you brought a model. So
Yeah.
sometimes a picture is worth 1,000
Sure.
words. So maybe tell us a little bit what's in your spine and maybe give us a little bit of a definition of it. And we'll talk later about how and what you do to the spine to try to make it better.
Sure.
So maybe some ideas. This is what part of the spine?
So this is our lumbar spine. Here we have the 5 lumbar vertebrae, and our sacrum is down below. This model is stripped down essentially to the nerves, the vertebrae, the bones, and the discs. So between each vertebrae, the vertebral bodies here are sort of like the bricks that hold us up. And they structurally hold us up, but between them we need something that allows us to flex and extend, and those are the discs. The disc is a tissue that on the outside is very hard, it's cartilage, and on the inside is a soft kind of mushy substance called the nucleus pulposus. So that disc is sort of like the shock absorber of the spine. It allows us to carry weight on the spine. Also has that give that allows us to lean forward and turn to the sides. So those two structures form the anterior portion of the spine, and on the back we have the joints, and these are joints just like we have everywhere else in our body that allows us to flex and extend, and again rotate. And what comes out of the little space in between here are the nerves that go down into our legs in our lumbar spine. And in the middle, the spinal canal, down in the lumbar spine, it ends usually, the spinal cord itself ends at L1 or L2.
That's the very
people.
top of the lumbar spine.
That's the top of the lumbar, and then the nerves kind of come down and go through those foramen into the legs and the upper thighs and some parts of the lower abdomen. And so, and then on the back, this is our spinous process. If you feel along your spine, that's what you're feeling when you feel along the back there.
So if you see someone very thin, that's what you see in their back.
Yeah. And if you just run your finger along most people, you can feel those little bumps. That's the spinous process. And there's multiple places here that can cause pain in people.
One of the more common things that I see and you see are people who've got disc problems.
Sure.
And disc problems could be, maybe go through some words. So we said the disc is that gelatinous material between the bones that it allows the bones not to hit each other and allow for flexibility. So there's a lot of common words out there. Disc bulges, disc herniations.
Yeah.
Tell us a little bit about what they are. And maybe you could show us a little bit where they would be.
Sure. So as we said earlier, the discs lie between these bones. Right behind the disc, these little yellow guys coming out here are our nerve roots. So, and within here, for this, in the back here of this frame is the joint. The disc in the front, it's shaped almost like a kidney bean. And again, the outside is hard and firm in a good disc. So through multiple causes, it's possible that this disc can be damaged. And what happens in this process is these outer cartilaginous layers can essentially break apart, and with a herniated disc, that disc material leaves the inside of the disc and now comes onto the outside. And where it usually ends up is within the spinal canal. And if it comes in contact with the nerve root, you could feel pain coming down your leg. If it doesn't come in contact with the nerve root, you may not have pain from it. But what can happen down the road is now that that integrity of the disc is damaged, the disc itself can cause pain and cause back pain related to the discs.
Yeah, there's a lot of nerves in the disc.
So what happens is, initially there really aren't any nerves in it. There's no nerves, no blood supply. But once that outer layer once the integrity of the disc is gone, and the body starts to repair itself, nerves actually start to grow into the nucleus. They grow from the end plate above, and blood vessels start growing in there, and you can get pain from the discs. And that's characterized with sitting intolerance or standing intolerance. So you sit for 10, 15 minutes, and you kind of got to move around and try to find a way to get comfortable again.
So that's the numbness people would describe, and on our exam we'd see weakness, or sometimes when we tap someone's knee or their ankle, we get a difference in their reflexes.
So if that material comes out and pushes on a nerve, that nerve that's being pushed on, in the distribution of that nerve, you can experience any of those symptoms. You can have pain is usually one of the first things you'll have. You can have weakness, you can have numbness, your reflexes. There's quite a few things that you can experience from the nerve itself being compressed, but usually pain is one of the first ones you'd have.
So as you said, the lower back goes into your legs, the nerves, the neck, it goes into your arms. So even though it might look not as thick or as big as the lumbar spine, because it's a little bit thicker, the bones, in the cervical spine, which just is to keep your head up and also give nerve innervation or help supply to the arms, you get symptoms in your arms. So I'm going to jump ahead a little bit.
Sure.
Someone who's gone through therapy and they've got a herniated disc, and they're just not doing that well. They've gone through various modalities of therapy, whether it's acupuncture therapy, chiropractic therapy, physical therapy. And you said a lot of people, even without any therapy, get better. Another group of people get better with physical therapy, modalities, different kinds of rehabilitative therapy. If that doesn't work, and that's in my practice what I see a lot, I refer to people like you, and that's where pain management comes in. So I want to spend a lot of time now on your expertise. So someone comes to you with, we call it intractable pain, or pain that's just not responding. You said you did your exam, you get your tests, whether it's MRIs, CAT scans, X-rays, maybe nerve tests called EMGs. How do you decide what to do with the patient?
Well, we take all that information and we try to correlate it together and see if it's consistent with the patient's symptoms and what the findings on physical exam are and on MRI. So, by taking the information that we have, we try to come to a diagnosis. And one of the things, you mentioned some things earlier, lumbago and sprains, these are very general terms, and we really try to, by the time they get to us, typically their pain is more severe. If their pain isn't that severe, or if it's moderate pain and has been for only a short period of time, we want to put them back into that physical therapy, chiropractic, conservative management group and say, all right, if it's not getting better, if you get worse, then you come back to pain management. And again, we're going to take the imaging and what they say and try to really figure out what the cause of pain is. And then from that point, we're going to offer the patient some treatment modalities.
Let's talk about the treatment modalities. That's what you specialize in. And on this program, we try to bring the people who do the cutting edge treatments. Being on Staten Island, being part of New York City, and I know you have a practice all over in Manhattan and Staten Island. Tell me, what are the newest kind of things for people who have intractable pain, who go to the doctors concerned they can't work, just aren't doing that well? What kind of things do you have available that are very cutting edge with regard to treating people who don't want surgery or are not surgical candidates?
Sure.
So tell us a little bit about what you do.
Well, for each, I think there are some mainstay treatments that have been around for a while for what we do, and then there's also there's a lot of change and growth and advancement in our field, and it's really exciting, and it makes me invigorated every day as I see the new things that are coming out. But it really depends on the condition of what's going on, the underlying problem, and a lot of what we do as pain specialists. I mentioned earlier that patients are either a lot of them are going to get better, and if they're not going to get better, then sometimes you're going to have to live with a degree of pain. So some of them of what we have to offer is really just means to assist the body to get better or to help them along the path of getting better. So some of those might include something which many people have heard of, which is just an epidural steroid injection. Now,
maybe you could show us where and what you inject.
So typically, an epidural steroid injection would be used for a condition where your nerve is, we talked earlier about the nerve being compressed. It would be placing a small amount of medication near where the nerve is being compressed, and that would be picked up through the MRI and through where they were having their pain.
And what medicine do you use?
Typically, it's a type of a steroid that's placed there.
And steroids are anti-inflammatory, so it might reduce some of the inflammation.
Exactly. So it's placing that small dose of steroid right as close as we can to the underlying problem. Steroids are something that have been used for a long time, but we've also realized over time that steroids are bad for you over the long run if you're on them for extended periods or on high doses. So rather than give people high doses of steroids orally, which they used to do, we take a very small amount with a very, very tiny little needle and place it right where where we want to fight that inflammation the most. And again, that's something that's been around for a long time. It is not an answer to the problem, but if someone can get better from their condition, if they're going to patch themselves up one way or another, this can facilitate that process or make it happen faster with less pain. So that's one of the more common procedures for sciatica type pain or pain going down the legs. For pain within the back, typically there's two major causes of that for chronic pain. And that's that disc degeneration that I mentioned earlier, as well as that you can have arthritis in these little joints that we talked about earlier as well. So, on a larger scale, it's about half, about 40% of that pain within the back can be caused by the discs and 40% by arthritis. For arthritis-related pain, we have some pretty good procedures that can help for longer-term relief. And the first one would be a block of the nerves that innervate these joints. Again, these little joints here, as you can see, are, it's about the size of my thumbnail. And what's good about the nerve innervation to these joints, the nerves that supply these joints, they're very small and they're in predictable places. So we could take a tiny little needle, almost the size of an acupuncture needle, and go right where those nerves are and essentially numb them and put a little drop of steroid on them as well. And what that does is, by placing that numbing medication on the nerve, it is potentially both diagnostic and therapeutic, because if we numb this nerve and you get up and your pain is better, people know within 5 minutes, and they'll say, hey, my back is better, I feel good. And we say, we'll walk around a little bit and let's get a good picture. And if their pain is resolved for the duration of that numbing medicine, we have the diagnosis that you fall into the arthritis category. For patients, sometimes, as people know, arthritis is not something that's going to get better. So for people that have arthritis, that inflammation, even when it goes away, it's going to come back. We also can go in there and use a different little needle where we can burn the little nerves to the needle. It's called a radiofrequency ablation.
So there are different things. Some patients of mine talk about their spinal stimulators or some type of pumps. Those are obviously for people with more advanced pain. And tell me, when do you decide to go further, and what are those procedures?
Okay, so a spinal cord stimulator is a device that is placed into the epidural space, and it's essentially two wires about the size of a coffee stirrer that lies above the dura, which covers the spinal cord and the spinal fluid. It is a treatment that is actually evolving almost on a monthly basis as far as what we can use it for and how patients are responding to it. So, as I said, it's done in 2 phases. One is a trial, where the patient will have, essentially it's done in the same manner as an epidural is, but we place these wires to these leads, they're called, to the corresponding spot in the overlying the part of the spinal cord that we want. And essentially it scrambles the pain signals that are being transmitted from the nerves to the brain. And we have new ones now where we're having just the results have been much better than they have in the past. And we can there's also new ones where you can put in different places, and it's very exciting stuff. And you know, you have to be an appropriate candidate for that.
So back to what I do, with no brain, no pain. If your brain doesn't perceive pain, you're not going to feel pain.
Yeah.
So this is almost like if I bang my hand and someone rubs it, I'm changing the signal a little bit.
Sort of.
Yeah.
And with the new systems, we're able to do that in a way where, you know, you can block the pain and not, you know, in the older modalities, you'd feel a tingling sensation in the area. But now they have ones where you don't feel tingling at all. We are using them in different ways for different pain syndromes, and it's very exciting. So we are very, there's different things that we can treat now than we could treat before.
In the last couple of minutes we're here together, I'd be remiss not to talk about opioids and narcotics. As pain management specialists, I know we have very severe chronic pain. Opioids are right now thought of as a terrible medicine or not good for people. And there's a lot of issues, but sometimes we need them. And in your specialty specifically, tell us a little bit about it and what you do to prevent problems. As I said, we only have a couple of minutes left.
Okay.
Tell us a little bit about opioids.
Well, it's a tough topic to cover in a couple minutes, but opioids were created. They were created. It's a natural morphine is a natural agent, and you know, they found that it alleviates pain. So we have receptors in our body that when these signals come up to the nerves, there's right where they meet in the spine, there's receptors that can block the transmission or slow down the transmission of pain. Opioids over time we found first we didn't really use them that much, and then they were overused for an extended period of time. And now that the pendulum has really swung the other way, where we've realized that pain is something that we can't get rid of completely, and it's almost a part of our lives. So, unfortunately, during that period where doctors and patients, we didn't really understand that we could be creating a new problem by the overtreatment of pain with them.
So clearly there's a need, and I know, and we have a lot of patients in common. You're able to treat them, and hopefully people are able to live a normal life even while they're on opioids. And you know, we just really want to make sure that everyone is taking them appropriately.
Absolutely.
I want to thank you. I mean, the half hour goes by so quickly, and with someone who's as expert and articulate as yourself. You're a good friend, and you take wonderful care of my patients. I want to thank you so much for coming, and we're going to have you back real soon, and we'll talk about some of the more intricacies of pain management. We talked about back pain today, which is such a common process. There's a lot of different things that you treat, and a lot of things that we all treat with regard to pain. So I want to thank you again for coming by, and have a good night.
Great, thank you.